All right, so we're going to do the labor part now. This is from 10 teachers. We're going to do labor normal and abnormal. Let's begin. So labor or human parturition is the physiological process that results in birth of a baby, delivery of the placenta, and the signal for lactation to begin. At a human level, it is a major life event for the woman and her partner that heralds the start of parenting. In terms of providing care to a woman in labor, attention must be paid to safety and clinical outcomes, but also to her emotional well-being and desire for a fulfilling birth experience. I'm going to skip all of this down to the part where an understanding of the physiological and anatomical principles involved in normal and abnormal labor is best summarized using the three P's. What are these three P's of labor? So that's the power, the passage, and the passenger. The power refers to the forces, firstly, the contractions of the uterine muscles that result in the passage of the fetus through the birth canal, and secondly, the maternal effort of pushing in the second stage of labor. The passages refer to the birth canal itself, which is made up of the bony pelvis, the muscles of the pelvic floor, and the soft tissues of the perineum. The passenger refers to the fetus in terms of its size, small, average, large, presentation that presentation, which is what is presentation? Basically, that part of the fetus entering the pelvis first. Example, the vertex of the head, the face, the brow, or breech and position orientation of the presenting part in relation to the maternal pubic symphysis, not public symphysis. Example, anterior, occipito-posterior. When the three P's are favorable, normal labor is likely to ensue, resulting in an unassisted or spontaneous vaginal birth. When any of the three P's are unfavorable, labor is likely to be abnormal, resulting in the need for intervention and with that an increased risk of morbidity or mortality. It is important that the labor and its outcomes are audited locally, nationally, and internationally to ensure that the best outcomes are achieved and that lessons are learned where adverse events occurs. Okay, let's stop here and try to understand these three P's. Okay, so now according to the 2025 WHO Labor Care Guide Implementation Resource Package, we traditionally labor was taught using these P's, but modern teaching frameworks now expand this to five P's, right? Let me just put this down here because this is very important. So modern teaching methods. All right, so traditional labor was taught using the three P's, the power, passenger, and passage. But many modern teaching frameworks now expand this to five P's, where we have the power, passenger, passage, position, which is the maternal movement and posture, and the psyche, which is basically the maternal emotional state. So all these five provide a broader framework, and it's consistent with the WHO Labor Care Guide, right? They emphasize a more holistic assessment of labor. So that's something I wanted to touch. Another thing, um, when we talk about, according to the current obstetric teaching, the WHO Labor Care Guide, the two P's of labor are basically, wait a second. All right, so the latest five P's of labor we just did, we have power, passenger, passage, position, and psych, right? So power is basically the uterine contractions and maternal expulsive efforts. This is basically frequency, duration, intensity, adequacy of contractions and maternal pushing. The passenger is basically the fetus, right? The baby itself, the size, lie, presentation, position, attitude, station, any anomalies. And the passage is basically the maternal pelvis and birth canal. So we look at the pelvic shape, the pelvic dimensions, cervix, vagina, pelvic floors, soft tissues, right? That's your passage. And then we have the position. The position is basically the maternal position during labor. So this is like, is the maternal position upright, lateral? Is the mother squatting? Is the mother kneeling? Is there mobility during labor? And then psych is basically the maternal psychological state. So you have anxiety, fear, confidence, support, pain perception, emotional well-being. So all these five are the latest P's of labor. So power, I told you, it's the force that delivers the baby. The primary power is the uterine contraction, which is involuntary. And then the secondary power is basically the maternal bearing down during second stage, which is voluntary, right? Okay, we'll look at all of these things in much more detail later on, but let's go ahead and look at the maternal pelvis first. So when we look at the maternal and fetal anatomy, we look at the maternal pelvis, which has the the pelvic inlet and the pelvic outlet, right? So let's look at the pelvic inlet first. The pelvic inlet or brim is bounded anteriorly by the upper border of the symphysis pubis, the joint separating the two pubic bones. So can you see that this is the joint separating the two pubis bones, right? And then anteriorly, so basically anteriorly, it's bounded by the border of the symphysis pubis, right? Laterally by the upper margin of the pubic bone. So here you can see the upper margin of the pubic bone here, right? And then pubic bone, the iliopectineal line and the ala of the sacrum. These are basically the two alas of the sacrum. And then posteriorly by the promontory of the sacrum. So here you have the promontory of the sacrum, right? So the pelvic inlet at this level, the above the inlet we have the false pelvis, below the inlet we have the true pelvis, and this little line here, anteriorly it's guided by the symphysis pubis, posteriorly it's guided by the promontory of the sacrum, and laterally it's guarded by the ala of the sacrum, the iliopectineal line, right? And that's something we know that basically creates the circular pelvic inlet, right? So if you want to appreciate the pelvic a little bit more, you can see that the is at this level. This is like a diagonal position of the hip bone. So you can see that this is the pelvic inlet and this is the pelvic outlet. The inferior part is the outlet, and the superior part, just below the ala of the hip bone, is the pelvic inlet, right? So the normal transverse diameter in this plane is 13.5 centimeter, and this is very important. It's very commonly asked in exams. The normal transverse diameter in this plane is 13.5 centimeter, and is wider than the anterior-posterior diameter, which is normally 11 centimeter, right? So the fetal head typically enters the pelvis or oriented in a transverse position in keeping with the wider transverse diameter. The angle of the inlet is normally 60 degrees to the horizontal in the erect position, but in Afro-Caribbean women, this angle may be as much as 90 degrees. This increased angle may delay the head entering and descending through the pelvis during labor compared to labor in Caucasian women. Let's stop there and understand this a bit. So basically, what it's saying is that the pelvic inlet is basically the pelvic brim, right? It's like think of the pelvis as a funnel. The pelvic inlet is the entrance to that funnel. It is the opening through which the baby's head first enters during labor. Now, the boundaries of the pelvic, we see it anteriorly, it's the upper border of the pubic symphysis, like that's the front wall, right? And laterally, you have the upper margin of the pubic bone, the iliopectineal line, which we also call the linea terminalis, by the way, and the ala or the wing of the sacrum, right? I'm going to show you a few pictures here that will help you see it. So here you can see, right? So this is the pelvic inlet and this is the pelvic outlet. And this is the false pelvis, and below the pelvic inlet is the true pelvis, right? That is something you can appreciate here. Here also you can see that this is the ischial tuberosities on the both sides. This is anterior border of the pubic arch, and posteriorly we have the tip of the coccyx, right? Okay, so laterally we saw there was the upper margin of the pubic bone, the iliopectineal line, also called the linea terminalis, and the ala or the wing of the sacrum. These structures make the curved side walls of the pelvic rim. And posteriorly was the sacral promontory. This is the forward projecting upper edge of the first sacral vertebra. So can you see here? The first sacral vertebra, the first S1 is basically forward projecting upper edge of the first sacral vertebra, right? So it's very, very important for you to know these four boundaries, right? So the shape of the pelvic inlet is basically oval. It's not round. But notice something important. The side to side width is greater than its front to back width, right? So can you see that the side to side width is greater than the front to back width? So the side to side is basically 13.5 centimeter and front to back it's 11 centimeter, right? So the transverse diameter is the widest measurement is 13.5 and the anterior posterior is 11 centimeter. Therefore, the wider area is basically it's the pelvis is wider sideways than front to back. So that's why the fetal head enters transversely. Why does the fetal head enter transversely? Because we know that as basically when you look at a fetal head, you know that the um, transverse diameter is basically the largest, right? So the fetal head tries to align its largest diameter with the widest available maternal diameter. That's why the fetal head enters transversely. So the baby usually enters with its head turned sideways. This is called transverse engagement. As labor progresses, the head undergoes internal rotation, usually bringing the occiput anteriorly. Example, to the left occipital anterior position for delivery. I'm going to stop here and show you what I'm saying. So here, can you see that the baby's biparietal diameter tries to adjust in a way that um, that it's easy for the baby to enter with its head turned sideways, and this is basically called transverse engagement because the pelvis allows for the widest diameter in the right to left axis, in the lateral axis, right? So this picture is going to help you understand what I'm trying to say. And this is basically when the baby enters with its head turned sideways. We call this transverse engagement. As labor progresses, the head undergoes internal rotation, usually bringing the occiput anteriorly. So when it internally rotates, the occiput comes anteriorly, and that's what we call the left occipital anterior position for delivery. We're going to look at the positions later on, right? So what is the angle of the pelvic inlet? The pelvic inlet is not horizontal. Can you see that there's an angle here? Right? So the pelvic inlet is not horizontal, instead it slopes downwards. Can you see that this inlet is sloping downwards? Imagine like a bowl tilted forward. Normally the pelvic inlet makes an angle of about 60 degrees with the horizontal. Now what happens in Afro-Caribbean women? In Afro-Caribbean women, this angle may be 90 degrees. It may be much more than 60. This means that the inlet faces more vertically downward. Why is this important? When the angle is steeper, the fetal head cannot simply slide into the pelvis. Instead, it has to descend more directly downward before engaging. This may delay engagement and descent, though it does not mean necessarily that labor will be abnormal. So just remember that in Afro-Caribbean women, this angle, this 60-degree angle that you can see here, is much more wider. It's like this, it's 90. But that only means that it delays engagement and descent. It does not mean that labor will be abnormal. Just something you should remember, if during an abdominal examination in late pregnancy, if the fetal head is still high, which means it's unengaged, maybe it may be because engagement has not yet occurred. In first pregnancies like primary gravidas, engagement often occurs before labor. And in multiparous women's engagement may not occur until literally labor begins. A pelvis with an unusually small inlet or abnormal shape can contribute to a cephalopelvic disproportion. A cephalopelvic disproportion is where the fetal head cannot enter the pelvis effectively. Okay. Um, Okay, so can you remember that the pelvis has three important levels, right? There's a pelvic inlet here, which has a normal angle of 60. This is increased in Afro-Caribbean women, it becomes 90. Then we have the mid pelvis, right? This is the mid cavity. And this normally has your 12 centimeter or 11 centimeter, right? The one with the lowest one is basically 13.5 centimeter, and this one again, the first one, the inlet is 11 centimeters, right? So 11, 12, and 13.5. It's increasing as you go down. Okay, so we have a pelvic. This is the pelvic outlet. This is the mid cavity, and this is the inlet, right? So the baby enters through the pelvic inlet, passes through the mid pelvis, and finally exits through the pelvic outlet. Think of the mid pelvis as the narrowest checkpoint of the birth canal. Okay, so boundaries of the mid pelvis. When we talk about this mid pelvis, what are the boundaries of this mid pelvis? Now focus here. Notice the difference. The pelvic inlet is the upper border of the pubic symphysis and the mid pelvis is the middle of pubic symphysis, right? So when we talk about this pubic symphysis, here the upper border makes you the upper border of pubic symphysis makes you the pelvic inlet, and the middle of pubic symphysis makes you the middle pelvis. This is because we move lower into the pelvis. So laterally, these are the sides here. Laterally, these two sides are formed by pubic bones, obturator fascia, and inner surface of the ischium, and the two ischial spines. These are the most important structures, by the way. Remember, pubic here in the mid pelvis, the lateral sides are basically made by pubic bones, the obturator fascia, and the inner aspect of the ischium and the two ischial spines, right? These are very important structure. Posteriorly, At this level here, posteriorly, you can see you will have the S2 and S3, second and third sacral vertebra. Okay, and the shape of the mid pelvis is such that it is not, it is unlike the pelvic inlet, which is oval, the mid pelvis is perfectly round. It's perfectly round, it's not oval. Why? Because the transverse diameter is 12 centimeter and also the anterior posterior diameter is 12 centimeter. In some books it has 11, but you can remember 12, okay? Now, why is this important? At the inlet, the fetal head enters sideways because the transverse diameter is larger. But in the mid pelvis, both diameters are almost equal. This allows the baby's head to rotate internally, usually bringing the occiput anteriorly towards the mother's pubic symphysis, which is the ideal position for vaginal delivery. So at the mid pelvis, the rotation, the internal rotation happens. The two ischial spines, these are the sharp bony projections on the inner side of the pelvis. They're extremely important because they are the narrowest part of the pelvis. This is why in many cases of cephalopelvic disproportion, they become apparent at the level of the mid pelvis because the two levels of the ischial spines, as you can see, there's an ischial spine written here. The two levels of the ischial spines create the narrowest level area of the pelvis. So why can we feel them during a vaginal examination? The examiner inserts two fingers into the vagina. The ischial spines project inward, so they are easily palpated, and this makes them a reliable internal landmark. So when you measure the station tells us how far the presenting part, or usually the fetal head, has descended in relation to the ischial spines. Now, the ischial spines are defined as station zero. So if the baby is at ischial spine, the head of the baby is at ischial spine, we say it's at station zero. If it's 1 centimeter above the spine, we say -1. If it says 2 centimeters above the spine, we say -2, and so on. And if it's 1 centimeter ahead of the ischial spines, we say +1, +2, +3, +4, and +5. When it's 5 centimeters ahead of the ischial spine, we say that crowning is happening. Okay, the more positive the station, the lower the fetal head in the birth canal. So station zero is basically engagement. When the widest diameter of the fetal head, the biparietal diameter, has passed through the pelvic inlet and reaches the level of the ischial spines, the head is considered engaged. So when do we say the head has engaged? When the widest diameter of the fetal head, the biparietal diameter, has passed through the pelvic inlet and reaches the level of the ischial spines, the head is considered engaged. So define engaged. Engagement is when when station zero has happened. Station zero is when the widest diameter of the fetal head, which is the biparietal diameter, has passed through the pelvic inlet and reaches the level of the ischial spines. Why do obstetricians keep checking the stations? Because during labor, they want to know, is the baby descending, is labor progressing, or is the head stuck? Right? So zero is engagement, +1 is below the spines, +2 is well descended, and +3 to +5 is well approaching crowning and delivery. Right? And -3 obviously means the head is high in the pelvis. -2 means it's beginning to descend. And -1 means it's just 1 centimeters above the ischial spine. Right? Also, remember to provide a local anesthetic for any forceps delivery. The pudendal nerve is blocked. We give a local anesthetic pudendal nerve block. The pudendal nerve passes behind and below the ischial spine on each side. So for a pudendal nerve block, we use the ischial spines as a landmark, right? For vacuum or forceps assisted delivery, we give a local anesthetic, which is your pudendal nerve block. I'm going to stop here and continue the video from the next section.